you. I'm one of the 30 residents here at Harbor, interested in GI actually. So I'll be discussing endoscopic vacuum therapy. Just to start off, no disclosures to disclose, as to be expected. So the question is, what is endoscopic vacuum therapy? And like Dr. Eysselein already introduced, it's essentially a form of non-surgical management of GI perforations and leaks. And like he mentioned, it essentially is a type of wound vacuum therapy, but internally rather than externally. So we literally take a polyurethane like wound vacuum sponge, cut it up, and actually attach it to the distal end of a nasogastric tube. And then we place that tube next to or even within the perforation, apply suction to it, and then let it essentially heal. So this negative pressure, again, just accelerates healing by improving blood flow. It pulls out inflammatory substrates, and then it also promotes granulation. It literally pulls the wound together. This was like introduced for GI type of procedures with lower GI leaks by surgeons with rectal perforation.
Okay, why don't we look? Can I?
So it was initially introduced within the GI repair literature for lower GI leaks, specifically rectal anastomoses leakages. But it was started to be used in upper GI leaks in the early to mid 2000s by the Germans. I think Dr. Lofsky in Germany actually kind of pioneered it for upper GI procedures. So the general technique essentially involves, again, cutting up a sponge, attaching it to the distal end of an NG tube, and then you guide that tube nasogastrically with the endoscopy along a guide wire to the actual perforation. And at the area of perforation, you can either place it intraluminally or actually within the perforation itself. You can choose to fix it with hemoclips and sutures, but the earlier literature actually just let the suction keep it in place because it would literally collapse the area of perforation around that point. And then you just apply either low, moderate, or high-low suction depending on the type of perforation and the size of the perforation. So the pros, it's very minimally invasive in that you're not actually performing surgery on these patients. It's a relatively easy technique to learn and employ. It avoids expensive and difficult to use tools such as such as stents and clips. And then again, the placement of the sponge at the end of the tube is actually protective rather than traditionally placing the NG tube within the stomach where it could potentially cause irritation and actually worsen perforations at times. The sponge itself is actually somewhat protective. And there have been a couple of retrospective studies, and some of them actually show similar or even better rates than just using over-the-scope clips or stents. The cons, you can't use these in free perforations. And then there are anatomic limits as well. Obviously, it's limited by how far it can go down with the scope. So it's perforations that are further down the upper GI tract or very deep in the even lower GI tract really can't be used. So our first case was a case of duodenal leak. A 58-year-old gentleman developed a duodenal leak right around the second portion of the duodenum following resection of a rather large retroperitoneal tumor. The injury was repaired surgically, but the repair broke down fairly rapidly, and other follow-up surgical repairs actually failed. We also tried endoscopic repairs with clips and an OTSC, but that also failed to close the defect. And of note, it's a decent-sized defect with about 1.5 centimeters. So we applied EVT with a sponge on post-op day 21, and this was actually placed within the perforation. We kept it to low continuous suction and had to replace it once at about 15 days in. Just as a side note, most of the literature does recommend replacing it at least once. If it's a prolonged period, say more than a week or so, there's no set guidelines on how far we should, how long after replacement we should do that, but it's essentially to prevent the sponge from breaking down or adhering to the surrounding tissue. And then we actually had leak closure on post-op day 49 with a follow-up CT way down the line that actually confirmed complete resolution of the leak. So these are the only sets of pictures I'll have in the slide for the interest of time, but you can see the sponge being placed within the perforation in the first picture over there. And then after 15 days of EVT, you see actually significant amounts of healing. Our second case was a case of esophageal-jejunal anastomosis leak. So a 62-year-old lady with a history of a gastric adenocarcinoma underwent laparoscopic total gastrectomy with the creation of esophageal-jejunal anastomosis. And the post-op course was actually complicated by the development of an abscess right next to the anastomosis. And then the drain output was actually very suggestive of an anastomotic leak. So we again tried repair with the more traditional methods, including sutures and then over-the-scope clip on post-op day 29, but there was a persistent about half a centimeter defect despite these interventions. So we again utilized the EVT right around post-op day 33, kept it under low continuous suction, and then after just 7 days, we noted significant improvement with near resolution of the leak, and then contrast studies subsequently afterwards confirmed a resolution of the leak. Our third case is the most complicated one, you can see it by the heavy bucket text. So we had a 37-year-old gentleman who had a resected retroperitoneal liposarcoma, which had significant involvement of the duodenum as well as the abdominal wall, and required the creation of pancreatic duodenectomy. On post-op day 7, he had a very quick increase in the amount of bilious output, which was very concerning for the leak, with CT imaging demonstrating free fluid within the abdomen. So basically, the surgeons concluded that there was a complete disruption of the surgical region. So they tried a surgical revision, which did not resolve the leak. He continued to have significant amounts of bilious output. So on post-op day 11, we actually initiated EVT and placed this one intraluminally. However, despite what we thought was secure placements, follow-up CT imaging a couple of days later actually demonstrated that the sponge had actually migrated out of position. So it was repositioned. We tried to fix it a little bit more sturdily, and then kept the suction going. On post-op day 18, we took another look, placed a stent within the fistula, basically to keep the aneurysm from closing. And then we replaced the sponge at that time. But again, a couple days later, when we repeated imaging, it migrated out of position once again. So the complicating thing for this case is that we weren't sure exactly how long the sponge was in place during that time. However, given the 2 previous successes we had, we elected to continue attempting to kind of reposition and continue the suction. And then actually, in our opinion, it actually helped close it faster than expected. The surgeons were surprised that we were actually able to have everything closed up and resolved by post-op day 46. And this is also on imaging as well as follow-up EEG. Our final case was a 48-year-old woman who had an esophageal leak after a successful gastric bypass surgery. It was a 2-centimeter leak noted based on drain output. She underwent EGD with, again, placement of a OTSC as well as stents into the area of perforation, but the repeat imaging on post-op day 35 continued to demonstrate a persistent leak with a rather small, like less than half a centimeter opening near the area where we had placed the cut. So we again initiated EVT, which was replaced once during our hospital course. And we had a couple contrast studies after placement. We showed gradually decreasing amounts of contrast in the drain. And by post-op day 59, the drain output at C, we took out the tube, and then again, imaging follow-up as outpatient to complete resolution of the leak. So our cases here kind of demonstrate the effectiveness of the tool, and in like 2 or 3 of the cases, we actually had resolution of the leak with this therapy, even though surgical, more direct interventions actually failed. And again, the ease of use as well as the relative safety of the procedure allows it to be well tolerated by even very elderly individuals, as demonstrated by 2 of our cases where the patients were over the age of 60. So, any questions at this time, concerns or thoughts?
Maybe just one comment. The surgeons say exchanges every 3 days. It's a lot of work endoscopically. So if you are intraluminary, you can leave it for 4 weeks. It doesn't matter. If you are in a cavity, I went for a week, 10 days, because it's just 3 days. It's very cumbersome. And a week is fine. there's always a risk that the sponge adheres to the tissue and you get some bleeding. Knock on wood, we didn't get it. So I think probably a week, 10 days, and what other people in Europe also do in the esophagus perforation, a week, 10 days, is probably a good time interval.
Tell us, sorry, Victor. Tim and Victor, could you tell us, like logistically, just getting the sponge? Are you kind of like running to the OR and finding a sponge, and also in terms of connecting it to the suction, are you using like a vac suction system, like a wound vac, or are you just connecting it to wall suction?
So I believe in terms of getting the supplies, again, it's very freely available in our OR, and actually I think it's available in a lot of our stock rooms as well. So getting the sponge itself, again, we make it ourselves, so getting the sponge itself is not a problem, it's just cutting it up and actually physically tying it onto the
A few tricks. When you do it for short term, you put the NG tube to the nose in the pharynx, the guide wire, you grab the guide wire, and then get the NG tube out to the mouth, and you suture the sponge to it, pull it back, and then with the guide wire go in the esophagus, and then push the sponge with the scope with the maybe forceps down. If you have to do it for 4-6 weeks, what I have done is putting a peg in, so peg tube. So you feed the G tube to the peg, get it out of the mouth, suture it on, pull it back, and then advance it down into the cavity. Because it's not nice to have for a long time an G tube in the nose.
Are they at home doing this treatment, or are they in a facility somewhere, or where are the patients?
No, most of the patients our patients are inpatients. Surgeries. They fed the surgeries and broke down, so there are multiple tubes and drains.
What kind of wire are you using? What kind of a wire do you use? Which type of wire do you use?
A guide wire?
Yeah, which type of guide?
0.035, yeah. 0.035 guide wire. And I shoot it just with silk, 20 silk on it.
So Victor, when you do the peg technique, you use the 24 French. Has to be a bigger peg than 20, right? If you're going to fit the...
Yeah, but you have the NG tube can be 60 French, 80 French.
Oh, okay.
That's no problem.
Actually, the smallest one is 12 French.
You can also use a PEJ setup. So you have to stop a leak from the stomach, and then just use the J portion. Basic.
Just like to acknowledge Dr. Eysselein, Dr. Reicher, Dr. Chen was actually one of the surgeons who helped us kind of implement these procedures, Dr. Fleshman, Dr. Amir, as well as the GI nursing staff over here.
Right. Thank you.
Thank you for your time.